Today we will have three moderators. The first one is from Scape, Dr. Wang, Li Jian. The second one is from Kaga, Dr. Mo, and Dr. Zhu. Yeah, maybe I will give the control to you.
Hello, everyone. Yeah. Can you hear me?
Yes.
Your camera need to be low a little bit, Dr. Wang.
What's the problem?
You only see half of your face.
Your head was chopped off.
Yeah.
Oh, okay.
Yeah.
Let's do this way. All right, this way.
Yes, better.
Is it better?
Yeah.
Okay. Hello, everyone. I'm Li Jian Wang, GI physician practicing in Florida. Today is a lecture by Dr. Chen on obscure GI bleeding, sponsored by both the Chinese American Physician Entrepreneur and the SCAPE and the Chinese American Gastroenterology Association, the KGA. As a member of both society, I enjoy very much the benefits of both associations. This past July is the 10th year anniversary of the SCAPE. And we have more than 800 active members practicing almost all the different specialty of medicine across North America. Our annual meeting usually has 200 to 300 member attendees each year. The next year will be in Orlando, Florida on June 28th and 29th, 2025. Led by the current president, Dr. Chen Lirong, and previous presidents, Drs. Chen Xiang, Li Gang, Hu Linqun, and Chen Xiongyin. The SCAPE always welcome new Chinese American physicians to join our society. To me, the SCAPE is like the community I live in. We share interesting stories of life and work, and common hobbies, and tips of travel and everyday life. For the KGA, on the other hand, is like my uncle room in hospital or medical school dorm. We share interesting GI cases and ask for help on challenging problems or questions and learn from each other, usually at bedtime after a long day hard work. And here I want to take the opportunities to thank all the three my colleagues here today. Dr. Chen, the speaker, he always has very interesting cases to share and teach. And Dr. Mu is like the encyclopedia of the KGA. And Dr. Zhu is a specialist in IBD and intestinal disease. Now I'll pass the topic to Dr. Zhu.
Hi, everyone. And I'm Cindy Zhu. I just want to briefly talk about our CAGA. And CAGA is Chinese American Gastroenterology Association. This is a nonprofit organization, and this is now part with American Gastroenterology Association under the special interest. And so the CAGA's object to enhance the education and professional development of our healthcare, all the medical doctors, and such as gastroenterology, hepatology, pathology, and radiology and oncology, and so on. And so who work in the field of gastroenterology and hepatology to have tied to our special Chinese culture and live in the Northern America. So our goal to strive to support our members and non-members through the promoting professional communications and sponsor medical educations and foster academic and medical practice and partnership. and advocating for training and employment opportunities. And additionally, and we'll reach out to our communities and then to serve them better. And in the coming years, now we're going to have a series of lectures and to educate and to promote ourselves. And so at this point, I will leave it to Dr. Mu to introduce our today's speaker.
It's my pleasure, and turn to introduce our featured speaker, Dr. Chen Zhongyu, or John Chen. And Dr. Chen was a medical graduate from Shanghai University, and he subsequently earned his Ph.D. from University of Minnesota in the field of microbiology and immunology. And after that, he stayed at the same university and did his medical residency and fellowship training. And during his fellowship, he has worked with some of the legendary gastroenterologists in U.S. history, such as Dr. John Bond and Dr. Michael Levitt. And as some of you may know, these two gastroenterologists reported the first case of gas explosion in the colon when they did sigmoidoscopy and cautery. That was back in 1976, if I remember correctly. And Michael Levitt moved on to analyze the gas in the bowel and develop hydrogen breath test, which is still being used widely in today's practice for diagnosis of small intestinal bacterial overgrowth. And John Bond moved on to champion the National Polyp Study and lay the foundation for modern colon cancer screening and guidelines. So he has the privilege to work with all these legendary gastroenterologists and then moved into a premier private GI practice, perhaps the biggest independent private practice in the US of gastroenterology, that is Minnesota GI, and he's now a senior partner physician there with his vast experience in the community GI practice and special interest in obscure GI bleeding. He's going to present a case series type of lecture to us, and I am so looking forward to it. Without further ado, Dr. Chen.
Thank you very much, Dr. Mu. It's indeed an honor to be presenting today, and in fact, I really have been very lucky to have quite a lot of renowned people in the GI field, working with them, learning from them, both at the University of Minnesota and at the MNGI, or MNGI now called Digestive Health. And it's an honor for me to also volunteer for the international committee. Now is an international subcommittee for the education committee of the AGA. And so it's a learning experience for me. And without ado, I will just continue with my talk today. Okay. I have no relevant disclosure. So I'm going to minimize a little bit. Okay, good. So obscure GI bleeding continues to frustrate both the doctors and patients, despite the advent of the very helpful small bowel capsule endoscopy. Okay. Not only, I'm sorry, can you hear me? Okay. It not only consumes tremendous medical resources, but also can you hear me? Okay. But also affects the satisfaction of both the patient and the doctor. And of course, it's my pleasure to share with you the practical lessons I learned from the community GI practice. Okay. So the first case, 69-year-old white male with alcohol cirrhosis, non-small esophageal varices, and a very recent diagnosis of MGUS with pancytopenia. He presented with 24 hours of melena and hemoglobin dropped from 10 to 6. A remarkable history of acute massive upper GI bleeding of unclear source with hemoglobin down to 3 and cardiac arrest less than a year ago. EGD at that time showed fresh blood in the stomach, but no clear bleeding source. And this is what I found. So EGD did show varices, but they are small. They're not really bleeding. In the stomach, there was old blood. And after washing the stomach, you look very, very carefully. You do see something a little bit of different. If I look at enlarge it a little bit bigger, you can see there's a white spot. There's possible a blood vessel in it. Okay, and this is a doulafoid lesion in the antrum, but it's not actively bleeding, so it's difficult to see. Clipped it, and then that's it. Now this is another case, but this case is very dramatic. You can see a pulsatile bleeding lesion in the duodenum with a lot of blood around. I wish I had a video, but I didn't have the video, just took a picture, but it wasn't spitting out right now, but you can see the knob over there, which is blood coming out. Okay. And this can be scary for the beginners, but in fact, if you know what it is, just a single clip or maybe two will take care of it. So just be a steady hand and don't be afraid of the massive blood around. And this is indeed a duodenal doulafoid lesion that was successfully treated with just 2 clips. In fact, 1 clip was probably good enough, but I just want to make sure that there was a good, well clipped, so I put 2. This is another case of 39-year-old white male who's a healthy police officer who presented with massive painless hematemesis and dizziness. He had no relevant history, really healthy person. And his hemoglobin dropped from 16 to 7. This is just before this year's 4th of July, you can see it, July the 2nd. And I did the endoscopy and there was completely blood in the stomach. This is actually after shaved some of the clot already. It looks like there was no active bleeding, but there was a huge clot attached to the fundus. Despite my shaving, I couldn't see anything. And in fact, I decided to quit just because there was no point of continue like this, and it was not actively bleeding. So the next day, after giving him IV Reglan, next morning, I went in again. The clot is gone. And you see this, a little bit of blood attached to a little small spot. And this is again a doulafoid lesion. The trace of the blood actually gave me a little good mark to work on. So I put 2 clips on it. And that's it. And he really did well. So doulafoid lesion, we all have learned about it, but in real life, you will see them. They are abnormal submucosal arteriole that erodes and bleeds, most often in the stomach. The etiology is unclear. They are difficult to see when not bleeding because really not like an ulcer that has quite an area. This is very small area of usually a tiny white spot with maybe a little blood vessels. It can cause life-threatening bleeding. Hemoglobin clipping, banding, or embolization are quite effective. Usually no need for retreatment. The next case is a 78-year-old white female with coronary artery disease, congestive heart failure, atrial fibrillation on apexaban, GERD, chronic kidney disease, stage 4, obstructive sleep apnea, type 2 diabetes, a lot of comorbidities. She has chronic anemia for 10 years with repeated negative workup, including EGD, colonoscopy, small bowel capsule. She was followed by HEMONC with increased need for every 2 to 3 weeks would have blood transfusion recently. So she had another EGD colonoscopy just 1 month before she came to see me and showed large internal hemorrhoid, okay, and sigmoid diverticulosis, but no active bleeding source. So another small bowel capsule was ordered, and I read it, and this is what was seen. So there was definitely blood in the stomach. And if you look carefully, there was a little bit of spider-shaped red lesion, okay, but it was not bleeding. So I did a push enteroscopy 2 weeks later and found a non-bleeding gastric angiodysplasia and a bleeding duodenal angiodysplasia, both ablated with APC, argon plasma coagulation for the other people. Another 2 weeks later, and 10 days after restarting Eliquis at a half dose, she was very happy because her hemoglobin rose from 7.3 to 9.7 with no blood transfusion for already over a month. And she was scheduled to have a Watchman device placed in the mouth. So this is what I saw when I entered the small intestine, blood. Okay, in the blood, small intestine. If I wash it completely, I don't know whether you can see well. There is one area that's it's almost like telangiectasia, but it's angiodysplasia, and I just abraded with APC, and that's it. Okay, so this was another one of angiodysplasia in the stomach, and if you use the water jet, it actually induced a little bleeding. Next case, an 84-year-old white female with transfusion-dependent iron deficiency anemia for almost 12 years. Had extensive unrevealing workup, including 5 EGDs, 4 colonoscopies, 2 small bowel capsules, and contrast CT of the abdomen and pelvis, showing only a duodenal diverticulum, colonic diverticulosis, extensive atherosclerotic cardiovascular disease, a pancreas division, and a pancreatic cyst. Hematology workup was negative. IV iron supplementation could not maintain the hemoglobin. So this is now a 3rd small bowel capsule endoscopy. And this is what it shows, okay. So on the left side was a small bowel capsule endoscopy. There was some stool there. You can see it's in the colon, not in the small bowel anymore. But you can see those areas of, looks like there is some bleeding going on there. And this is the colon.
Sorry, somebody.
Dr. Chen, I think your speaker is muted.
Oh, okay. Now, can you hear me?
Yeah, we can.
Okay, I'm sorry. So the angiodysplasia, angioectasia, or sometimes we call them AVMs. Probably it's a misnomer, but anyway, they are small ectatic and thin-walled vascular malformation with little or no smooth muscles. Angiodysplasia more discrete, probably, often in the stomach and the proximal small bowel. Angioectasia more diffuse, more in the proximal colon. Again, the nomenclature is still quite confusing at this time, but they're kind of used interchangeably. Probably the most common cause of obscure GI bleeding because they cause intermittent and slow bleeding, which can be aggravated by antiplatelet and anticoagulation agents. They are often overlooked because they may be small, non-bleeding at the time of examination and blend into the vascular background. But they should be easily differentiated from the barotrauma in the colon. They are very distinct. Okay. More often in the elderly, vasculopathic, and those with chronic kidney disease, heart valve abnormalities, and LVAD. in part possibly related to the disruption of the high molecular von Willebrand factor. Okay. They respond well to APC ablation, but are often recurrent and at multiple sites. I have a very low threshold to treat the upper GI angiodysplasias in any patients with iron deficiency anemia because they are exposed to gastric acid, bile, and digestive enzymes. Pharmacotherapy for refractory cases now are available, and I would just touch a little bit on this. This is a study in this year's gastroenterology by a Dutch group, and that they compared the octreotide versus standard of care in angiodysplasia-related bleeding, the OCEAN study. They basically halved the need for blood transfusion in a year. Okay. This is another study actually came out last year, November, from China. And this is a comparison of non-endoscopic treatment of, the comparison of placebo with thalidomide with different dosages. And they essentially more than halved the bleeding. So this was published in the New England Journal of Medicine. Let's continue. A 79-year-old white female with slowly progressive weakness was found to have severe iron deficiency anemia, hemoglobin 5.2. Occasional celecoxib use for musculoskeletal pain, negative colonoscopy to terminal ileum except for diverticulosis. Outside EGD reported hiatal hernia, and the patient was already on PPI, pretty high dose for GERD. Reactive gastropathy, and negative duodenal biopsy. And this is what we found. And a big hiatal hernia and these linear lesions, ulceration. So it's a large hiatal hernia with multiple Cameron erosions. You probably see them quite often, okay? And since the patient is already on high-dose PPI and still having problems, and she was referred to Nissen fundoplication and hernioplasty, and that's the treatment. So Cameron lesions, a mucosal breakdown, often linear of the gastric folds, constricted by the diaphragm associated with a large hiatal hernia, aggravated by NSAIDs, and frequent cause of iron deficiency anemia in the elderly, and they respond to hernioplasty. Next case is a 51-year-old white male with intermittent iron deficiency anemia, a negative initial EGD colonoscopy, but a possible lesion in the distal small bowel, 87% of the small bowel in the small bowel capsule study. MRE was done, and it was unrevealing except for mild arterial enhancement in the terminal ileum, suspicious of Crohn's ileitis, and slightly engorged mesenteric blood vessels supplying more proximal area. A repeat colonoscopy showed a large ulcerated lesion that sprang back from the terminal ileum during the biopsy. This is what I saw, okay? A big mass. There was a little ulcerated area. I was going to do biopsy. In fact, I did biopsy, and then it disappeared all of a sudden. Okay, so this turned out to be that the patient did have surgery, a large distal small bowel lipoma causing intussusception. The question is why it wasn't showing up in the MRE. It's because if it was mobile, that's a possibility. So we have to be careful about sometimes the interpretation of our tests. As you know, MRI is a little bit slow. So if a mobile object, it may actually show it quite obvious. A 55-year-old white female presented with 4-year history of iron deficiency anemia, thought to be secondary to autoimmune atrophic gastritis. She had a 2-year history of intermittent melena, and hemoglobin dropped to 7 or 8 from normal, with dizziness and short of breath. And she also had extensive negative workup, including 5 EGDs, 2 colonoscopies, 2 small bowel capsules, a push enteroscopy, a CT enterography, a repeat push enterography, after another episode of melena and blood loss of anemia, reported a 2 millimeter, actually it's not an enterography, it's a push enteroscopy, showed a 2 millimeter angiodysplasia, 110 to 120 centimeter from the incisors. It was treated with bipolar heat coagulation and a hemoclip. But the patient returned within days for recurrent melena and hemoglobin drop. So a third push enteroscopy was performed. This is what I saw. Okay, I saw the clip. In fact, there was a mark for me, but I also saw this. There was a clot attached to almost the opposite side of the wall. So I washed off the clot, and then there was bleeding. So a bleeding site was injected with epinephrine and Indian ink marked. 2 more clips were placed. And so what is this? Is that angiodysplasia? So looked into the CT. This is a CT enterographies about 1 year apart. The left was the first one, and this is the second one. Second one, this time you had the clips over there. So actually it kind of marked the area where the area of interest. So there was something a little different this time. Showed prominent vasculature at the site marked with the hemoclips and possible wall thickening. And the patient had an exploratory laparotomy, removed 8 centimeter mass with only a small hyperemic mucosal area, mostly outside. The pathology diagnosis is GIST stage 2 arising from cirrhosis adjacent to the mesenteric fat. Another case, 57-year-old white male with a history of Roux-en-Y gastric bypass over 10 years ago and heavy alcohol use. He presented with persistent iron deficiency anemia, despite oral iron supplementation, quitting smoking, and cutting down the alcohol. Used to be 6-pack down to 1 beer a week on the weekend. He was already on PPI and Carafate therapy, EGDs, refractory anastomotic ulcer for over 2 years. No varices, reactive biopsy reactive gastropathy on biopsy, negative H. pylori, but the biopsy also showed occasional positive iron granules on biopsy. So no NSAIDs, no NSAID use, colonoscopy, small bowel capsule, endoscopy were unrevealing. So 3 months after switching from oral IV to oral to IV iron supplementation, the patient had close to normal hemoglobin, and repeat EGD showed healed ulcer. So was the ulcer healed because of correction of anemia? Or was the anemia corrected in part because the ulcer now healed? Or the ulcer healed in part due to no more irritating, eroding iron granules? In fact, I talked to our pathologist, and they do think iron granules can be eroding in the stomach. So the post-Roux-en-Y gastric bypass iron deficiency anemia, the dilemma is whether oral or IV iron supplementation. But I think if people who have ulcers, I would probably use IV iron. This is coming to the end now. This is a 33-year-old slim Asian male, had partial small bowel resection for volvulus on day 2 after birth in Hong Kong, complicated by a leak, an abscess, and prolonged TPN. So he had recurrent painless melena and hemoglobin drop from normal to 7 to 11. Similar episodes 2 years ago with negative workup, CT angiogram, enteroscopy, colonoscopy, macroscan, everything, except the small bowel capsule did suggest possible anastomotic erosion. We wanted him to have a double balloon enteroscopy, but he didn't follow up because he felt fine after the bleeding episode ended. He didn't use any NSAIDs. CT angiogram again, this time was negative. So we had to proceed with intraoperative push enteroscopy for another episode of melanin hemoglobin drop. And this is what I saw. In fact, there was so much adhesion that they did the operation lasted for a whole hour. So they just kept lyse the adhesions. So I saw those things, they are not really related to the disease. The mucosal tears from adhesion lysis and advancing the scope because they helped advance in the scope. The surgeons pushed the scope forward and forward. But the active bleeding was noted at the anastomosis. And it was resected, and they redid the anastomosis. So the pathology report was a disrupted anastomosis with 1.5 centimeter ulcer. So I actually caught him just recently. This was after 2 years. He was remember, he was a slim person. He now gained 12 pounds. So he was pretty happy. So in summary, obscure GI bleeding may have not so obscure causes, so long as they are not overlooked. Different causes of obscure GI bleeding have different bleeding patterns that can help distinguish them. Repeated studies may indeed be necessary in some cases, but with extreme carefulness and knowledge and experience, we should all try to be the terminator of the endless search. Pharmacotherapy is now available for refractory small bowel angiodysplasia-related bleeding. So this is the patient who is a police officer who lost almost more than half of his blood. And he was extremely happy that we did what we did for him. In fact, he went up to North Minnesota to have the 4th of July weekend. I said, it's okay, don't use alcohol. That's all. And he was on PPI a little bit. So the patients really appreciate you finding their obscure GI bleeding sources for successful treatment. But they are also the best teachers who taught me everything I shared with you tonight in real practice. Thank you. And I would like to have any questions.
Thank you, John, for sharing your wonderful experience with all of us, and we learned a lot from you. It's fascinating that you pointed out how a lipoma was missed by MR enterography, probably by motion effect. I know exactly what you're talking about because I've seen that before with the lipoma in the terminal ileum that just flip in and out very quickly. So do you think if that patient had the CT enterography, they might have seen it instead of MR enterography?
I think so. Yeah, but that patient did the MRE instead of CT enterography for whatever reason they ordered. So,
yeah, for Crohn's disease and stuff, we think MRE might be more advantageous than CT, but in that particular instance, perhaps CT is better.
Absolutely. I think they were concerned about Crohn's disease, and that's probably why they ordered the MRE. Yeah.
And the other question I have is thalidomide, which was published in the New England Journal of Medicine. In the old days, female hormone, estrogen was used for AVM treatment for prevention of recurrent bleeding, and thalidomide as a TNF alpha blocker. And what is the mechanism for that? It's fascinating.
It's not well known, to be honest. I know you like the mechanism. I actually met the author of that paper when I went to China recently, and she actually still told me that the mechanism is still not quite clear. But you remember thalidomide has been associated with deformity of fetus. It may have to do with angiogenesis. So that might be the mechanism of why now it may be helpful.
Thank you.
One thing you mentioned about thalidomide I would like to talk about too is that I put my patients on thalidomide, but it had to be prescribed by the HEMONC because they have a special license for doing that. But it was terribly expensive in the US. And
Interesting.
yeah, some of the patients couldn't afford. But when I actually asked the author of that New England Journal of Medicine, Chen Huiming, I think, from Shanghai, and she told me that dose in China was 840 yuan. So for 4 months of treatment, 100 milligram. So if somebody can get some of this over to the US, it can be very helpful, but I don't know why, they cannot get it.
What a difference. So John, it's a great talk. And yeah, thank you so much. And then so I have a questions about the gastric bypass patient. So what is the mechanism? Like you take away the iron supplements by mouth and then the ulcer go away. It's very fascinating. So we see this all the time in those anesthetic ulcer. They never heal and always coming with is a bleeding. And then they frequently they are on iron pills. So how many cases you have been seeing in those patients take away the iron pills?
I actually talked to my colleagues because they did actually have some of them shared the same experience. So in MNGI, because I did bring it up, and then to the pathologist, MNGI has our own pathologist, and then they did say that yes, indeed, it can be erosive. These granules can stay there for quite some time, and daily dose can be erosive. And it also, and another partner actually told me that it could be the preparation too. So sodium sulfate versus sodium other things, not iron sulfate and iron other things. Some of them are not as erosive, but some sodium sulfate is probably the most erosive. I mean, not sodium, iron sulfate.
Iron.
So that can be an issue. So different preparation makes a difference too.
I see. Yeah, another thing is in your case too. So it appears that the capsule endoscopy and it helped. And so I also had a similar, the experiences for those. And then it couldn't find anything upper and lower, of course. And then doing capsule endoscopy, amazingly, you can see some, it's just in the proximal and then we miss. And it's not that we miss, and it's just because they're not, like you said, and they're intermittent bleeding. So sometimes I just keep the patient on anticoagulation and then do capsule. And then once we find out, and then we can do push endoscopy, or just repeat the EGD. They are just in the proximal. So it's amazing you also had a similar, experiences and then for that. Yeah.
Yeah, this is actually a part of, I actually gave a similar talk to the MNGI internally too. So because of for kind of education of new gastroenterologists who came in from fresh from training. So very often, and then the surgeons too, they don't pay attention to those. These are tiny little things, so that's probably what contributed to many procedures done and then didn't find it. And recently I had another case of iron deficiency anemia who the patient had not only GAF, which was treated, but quickly came back to with iron deficiency anemia. And she wanted to go to Florida, and she really wanted to get in, before she went to Florida. So I did it, I repeated. Yeah, actually the GAF was treated okay. And there was an AVM in the duodenum, so angiodysplasia. So I abraded that, and so far I haven't heard anything from her now. So she was doing probably well. So it can be very easily missed because, as I said, for the reasons you mentioned too. So the little extra carefulness in the upper GI, I think it can make a big difference.
Yeah.
Okay, there's a Dr. Fan in the audience that asked a question: how do you detect the GI melanoma before metastasis? I myself only see one case of anal melanoma. I never I never had. It's very rare to have a GI melanoma. Any experience, Dr. Chen and other doctors?
I personally haven't seen one by my own cases, but my colleagues did find there was one case of small bowel melanoma. Because we have a small bowel group, so we discuss cases, and one was presented as the patient had melanoma actually quite a few years ago. And then there had new bleeding, and then there was a lesion, eventually had surgery, and it was a melanoma.
Actually, I can make a comment about that.
Yeah.
I've seen one a few years ago, a male patient in his 30s who had recurrent iron deficiency anemia for about 3 years, had typical endoscopy, colonoscopy, CAPS endoscopy twice, and couldn't figure anything out. And then one of my colleagues ran the case by me, and I said, hey, I'll be on call in the hospital. Why don't I do a push small bowel enteroscopy? I'll go as far as I could. You know, sometimes people think you've done capsule endoscopy, you don't need to do push enteroscopy. I'm not always a believer of that, because the handheld scope do give you a better advantage. You know what I found? A big black ulcerated hole in the small bowel, very, very far at the very end of my reach. And when I biopsy it, it came back malignant melanoma. And we sent him to see 2 different dermatologists, did a careful total body skin exam. Absolutely no skin melanoma anywhere else. So by definition, that is called the primary GI tract melanoma. But how melanoma happens without UV light exposure? The gut does not see the sunshine. So the theory is actually the so-called primary GI tract melanoma is caused by metastasis. And after the primary lesion metastasized to the GI tract, for whatever reason, the immune system overcome the primary lesion, and that disappeared. And the matter of that, the metastatic lesion persisted and grew. And so that was a fascinating case, as you mentioned about the melanoma of the GI tract. I've seen it in the stomach and other places, but usually you have a primary lesion somewhere else. And the case I saw did not. And also that case was not seen by small bowel CAPS endoscopy twice. Our speculation is probably because it's so black and dark, you couldn't see much in that segment. You think it's debris. The whole camera just floated through and without detecting it. Anyway, that was my 2 cents experience about the melanoma in the GI tract.
Yeah, very interesting.
Hello, everyone. Yeah, this is Mimi from MD Anderson. Speaking of melanoma metastases to the GI tract, I hope to share some of the experience that I have at MD Anderson, since, I'm kind of scoping a lot of patients with cancer, especially melanoma is one of the most prevalent one. So the few, I would say about maybe 10 patients that I have probably scoped and have kind of confirmed the melanoma metastasis in the GI tract, and more in the upper GI more than the kind of lower GI tract. But one of the most impressive case is that the patient only presented with nausea, vomiting symptoms, and I was worried that this patient may have immunotherapy-induced upper GI toxicity. That's what we treated him about 2 years prior to that, and he responded to infliximab very well. So we left him alone for all these years because his cancer was in remission, until 2 years later, he suddenly presented with all these recurrent symptoms of nausea, vomiting, and diarrhea. So that's how kind of I have this mentality in my mind, hey, this is a recurrent GI toxicity. I'm going to see all this inflammation again. But the minute I went into the upper GI tract, I see numerous black dots in the stomach, in the duodenum. And I went to the colon. I also see numerous black dots throughout the colon, but it's less intensive than the upper GI tract. So I immediately know this is metastasis melanoma, because it's so impressive. Other than sporadic black lesions, as what Dr. Mu has mentioned, also that's typical kind of black lesions. So biopsy confirmed it, and unfortunately that patient passed away very quickly because of this kind of full-blown metastasis and melanoma. Within very short period of time. But that's, very impressive experience that I had, that, I almost show it to anyone whenever talk about this topic. I want to show that pictures. But thank you so much for the topic.
Wonderful. Thank you. Wonderful talk, John. I have a question. I have the case I run by to see if anybody can help me out. So there's a patient with a deep duodenal ulcer with the bleeding, massive bleeding. I was told to use the all these type A or type B blood in the whole city, and then still cannot control it. So they did an angioembolization, finally stopped the bleeding. Now this as a repeat because we need looking for the like H. pylori, etc. So 4 weeks afterwards, I did a up endoscopy and no further bleeding, but I can feel the angio coil through the duodenal bulb. Now this is the coil there. It's a so this is actually in the past this will be my third time, fourth time as I see this in my career. This now it's a time bomb, tickling time bomb, or so that I actually sent this for 3 surgeons. I said, should I do something? You know, or just wait. And what's the experience? So you can see the thread is out. Is the coil is out of the duodenal bulb. What should I do? It's not a surgical candidate, by the way.
Yeah,
So,
I have seen a case like that too. But I think I send them to the surgeons. In fact, they need surgery. That's my personal experience, and they did. I actually had another case that bled like crazy, and then actually he turned cold because he had to. It was his temperature went down so fast that we had to get the surgeon in. I couldn't see anything. The surgeon insisted me doing a endoscopy, try to find out. It was all blood. It was just a mass. I used double channel. I couldn't see. I suctioned so much. But I could tell that it was from the duodenum because the fresh blood had a little different color than the old blood. So that patient actually, the only way is surgery. So they couldn't even go to the interventional radiology, but just 2 stitches. That's
so basically we talked to one of the stitch that before when I was Cleveland, and then people to stitch. But there, one of the surgeon here is need a partial entrectomy with a vagotomy. So 3 surgeons has 3 different ideas, so that made me confused. So there's I just watched.
Jim, you have any comment? You've seen?
Yeah, I've seen something similar, but not in the same way. Professor Chen, I'll share with you. So we had a massive GI duodenal ulcer bleeding with a huge crater. Endoscopic treatment failed multiple times, and you call the surgeon says, "Oh, go to IR first." And I'm always a little nervous about IR because you got a big ulcer and you embolize the vessel and you cause ischemia, and an ulcer just does not heal as fast. So in this particular patient, IR embolized and bleeding stopped, and a few weeks later came back and bleeding again. They did a CT angiogram and said, oh, there was a perhaps abscess right next to the duodenum where he had an ulcer, perhaps contained perforation. So they called IR instead of embolizing more. Of course, you can't do that anymore. They put a catheter to drain the quote unquote abscess. And a few days later, the guy had coffee emesis. The surgeon said, GI, the patient is bleeding again, please scope. I say, well, what do? If you stand by as a surgeon, you know, if he has a abscess there must be an open channel communication or something. I may make it worse, but if you stand by, I'll do it. So I went into the stomach. It was full of a coffee ground material in the duodenum in the stomach. As I was looking around, I saw the IR catheter. So basically, there was a huge defect in the medial wall of the duodenum that was probably ischemic, and it just totally lost. I sent the patient back to the surgeon, go fix it. I say, what do you expect me to fix? You know, in that portion of duodenum, it's not easy just to resect it. They put him on TPN. As long as he's not septic, they just expect him to heal. I was not confident about that at all. Well, 3 months later, the guy came back to follow up with me in the office. He looked great. And I scoped him. The whole thing healed up completely. And that hole was sealed. So the surgeons were right. And I don't know what to do with the vascular, because if that coil ruptures, it's going to bleed pretty bad. I have no idea how to approach that. I'm pretty sure the surgeons are nervous too. If they poke around that and triggers bleeding, it might be too much for them to handle. Fascinating though. It would be nice to get a follow-up from you a few months later.
Nowadays, in the angiogram, in the angio field, there will be a coil, the old timer, now also glue. I wonder if the glue will be better. So there's maybe I don't know which one is more efficient. And
sometimes they do both, a coil followed by gel foam.
Yeah. So, but it's like every time I do the duodenum and control the bleeding, I tried to use mechanical force, use clips, use injector. Nowadays called a pure stat gel. And if you diffuse a bleeding like this, I do D50, especially what we call the aliquis or the pelvic stomach. It's like you see the diffuse bleeding, but you don't see the ulcer. So what do? I just spread a lot of sugar there. If the large area, if the tiny area, use a pure stat.
So after you inject the D50, and what is the permanent, like long term?
No, it's like I would do it is it's not injection, spray. It's like we published even the case report of diffuse jejunum 12 centimeters like radiation bleeding. So there's no spot, the oozing, actively oozing, just no ulcer. But this segment is like a radiation. So you instill the 200, 300 cc of the sugar there. Actually, also good for the diversion and pelvic stomach and aliquis stomach, because it's pretty safe to use. I always nervous. Happened to me. It's like a APC and the epinephrine. If you have to be second look, if you do the inject APC or they do the APC and the epinephrine, if you have a second look at the areas that are ulcerated is looking really ugly. There's an incident that happened when I was in Cleveland. There's a AVM, so I did an APC in the right colon with the right setting, and it caused a perforation, a late perforation, like 48 hours later. So this is so that then since then I try to use all the mechanical force, like I love clips, and then also I like spray the sugary things. Hardly ever use the heat probe and the APC or except only exception probably positive bleeding, you have to be using epinephrine. Otherwise I had hardly use because I've been burned. And I wish it's like a thalidomide would be helpful. I wonder if the thalidomide has been used for IBD. It is for the IBD person. See if we can get like similar certification or something to order it, because this use as a to sort of like a IBD slash the GI bleeding drug, because many years ago there's an estrogen study from Spain, right? Didn't work. So
Dr. Chen, rather than D50, why not hemospray?
A hemospray, I have a bad experience, harder to use, and then the immediate effect is look very good, which I tried it. This is not very effective, and as compared to sugar. Remember, if you many years ago, somebody maybe like Dr. Mo, maybe the same year. In my years, we use that time the injection, 25% of the sugar injected treat the varices. Varices into the varix vein back in the early 80s. And then I think this, if the sugar is can be injected into the vein, I think the spray is okay. Because in the IBD field, we quite often also do the balloon dilatation for the like inflammatory stricture. When you stretch it, and the diffuse oozing, so the sugar will be better. I don't have a great experience in the hemospray, and especially now it's coming out. Is everybody maybe use? If you have not seen the pure stat, that stuff is very good. I think that by potentially decrease my procedure-associated bleeding, the balloon dilatation, probably by 90%. So the pure stat replaced the hemospray.
P50 is because of its higher
Yes,
osmotic.
osmolality. Actually, you can see the Japanese use 3% of 3% of the saline. Same concept. So the 3%, and it used to be in like the 1970s, the late 70s, early 80s. We also used use ice water that time. If you the bleeding, we tried everything. Yeah.
Maybe for diabetes patient, we can use a highest concentration of saline.
Yes, I don't know, see the 3% of the saline available in the United States or not. For my radiation enteritis patients, the people had the diabetes. We just put the patient in ICU, they monitor the sugar well, and actually the sugar not increased. So we just instill the sugar there. So it's very, very useful. And
So
we used to use hypertonic saline, 3% for some of those.
Do we have? I don't know.
We have used it before, hypertonic saline 3%, but not spraying. It was injecting into the submucosal, and it causes tissue swelling and then temporary controlled bleeding. Of course, it's not a permanent control. Hemoclip, if available, is obviously it's more durable.
Yeah, I love hemoclip.
So, Bo, at the end, your case is sent to surgeon, right?
So they said, why still waiting? Because sleep
so-
surgeon has 3 different opinion. If the sleep surgeon says the same thing, I would do it. I pick up to this.
I would send it.
What is a vagotomy with the entractomy? What's the overseeing things? Another one is an aortogram or something. It's like, oh, this is like, if you have a different opinion, that means I don't know which one is right. So the one many years ago I did it in Cleveland too. It's with the dislodged, but not as much as they come out. I can see the hole. So basically, I put a clip there, put a lot of the clip there, and tried to close the hole. That it was okay. But this one, you can see the thread, probably about, I would say, 3 to 4 centimeters along. The thread come out, the coil come out from in the duodenal lumen.
I would send it too, because it's through the vessel coil eroded to the.
It's the aorta, the duodenal, fistula, right? So eventually will cause the trouble.
Absolutely.
And the gentleman is a little bit obese, and then so that no sign of the bleeding. Because from the Jewish community, because we have a good Jewish outreach, they are very knowledgeable. So there's like a referral resources that we call high medical, and versus like a patient family, a lot of the discussion, what do we do? We just wait and see. I said one day the burst would be really bad. Maybe if the burst, maybe to the clip, if you,
Well, maybe you should have sent only to one surgeon, not 3. Was I kidding?
Yeah, so they actually because this you know what? Actually, this we have a very knowledgeable Jewish patient population, and then the referral service. A lot of the question. The question is, ask a surgeon, have you done this before? How many of them? But if you say that only 1 or 2, they are not convinced. So, yeah. And other things, I probably a little bit run out of similar. I'm sorry, if like the same. We see a lot of anastomotic bleeding from the colon. The anastomotic bleeding harder to control, and then we have an incident that people send for angio. After angio, the ischemic also get worse and bleeding more. So that for the especially colon anastomotic bleeding, try to avoid angio. So that's my opinion. I truly enjoy John's lecture. Wonderful. I learned that. Yeah.
Thank you. Any other questions?
I guess that's it, huh? Thank you, John, and
you.
thanks
Thank
to the
you.
panel
Thank you
and
very much.
and
Nice
Kevin
seeing
and
you,
Dr.
everyone. Thanks
John.
for